So um, this isn't really. There's not many questions on the test about this. I'm joking. Okay. God. I mean, you, so please make sure. Please try to pay attention to this. And you're obviously not going to learn it if you don't. If you do immunizations, you should be pretty familiar with most of this stuff. Now, there's some questions at the end that I've given you that are going to hit on some areas that I don't cover, where they ask you weird stuff about someone getting, immune globulin and how long do you have to wait to get an MMR and all that stuff. So they're going to ask you some weird questions like that that don't come up very frequently in real life. And normally you would just go look up in the red book and see what the answer is, right? But they expect you to know, some of these crazy details. So unfortunately, you're going to have to know all these crazy details for this test. So the schedule, as you know, it changes frequently. Sometimes it changes 2 or 3 times a year, depending on some new vaccine has come out or some new combination. And again, when you're answering test questions on the test, so when you're there in October, or if you're restarting whenever you're taking it, make sure you're going with whatever the latest thing that just has been out. So because that's probably what they're trying to test on now. Saying that, they may have an old question where there's the right answer isn't there. Then what I always do is revert to what was the previous correct answer for that. So if the right answer is not there, then the guideline changed recently, then they're still using an old guideline and just pick that old answer. Okay, you all know where the schedules are. You have plenty of them. We're going to go through these. This last one, you really need to spend some time reviewing the first 104 pages of the 2000, and I didn't look to see how many pages. And when we did these slides, we did about 3 months ago, so I didn't have my red book yet. But it actually is helpful if you just kind of look through that, if you have some time to just as you go through it, you already know the information, but you'll see things in there that will help you answer some of these questions. So what I've done is essentially in this hour, we're going to cover those 104 pages, okay? So, all right, miscellaneous facts you just need to remember. If for some reason the kid didn't get their vaccine when they were supposed to at the recommended visit, then you want to, at the first time you see them, you give it to them. So if they're showing up in an emergency room or a urgent care center, give them the vaccine, okay? So give them vaccine. So they're going to ask you about that. Okay, here, Johnny broke his arm. He didn't get his, DTaP or whatever, or his hib or whatever it is, then go ahead and give it then, okay? Not in that arm that he broke, but, okay. Remember, they may ask you about the vaccine information statements. You always give, and I know you spend a lot of time going through these with your parents, right? I'm being facetious. I mean, the nurse gives it to them. There's like 6 of them now, or 8 or 9, sometimes. And you just hand these to the poor parent, and they're just like, okay, what am I supposed to do with this? And say, well, at least you're not having to read 104 pages in the red book. So, okay. And remember the vaccine adverse event reporting system, the VAERS. So that's where you're going to report any adverse event. And they could just ask you that. Sometimes they've asked where you've had an adverse event occur, who do you want to report it to? So just a simple question like that. Okay, so let's just start out with a question first. So which of the following vaccines, I guess it should be, is live, or which of the following vaccines are live? Is it hepatitis B vaccine? Is it IPV? Is it DTaP? Is it Hib? Is it the pneumococcal conjugate vaccine? Or is it rotavirus? Which one of these is live? So you have to figure out where your F is on there. It's after the number 5. It's number 6. Okay, just to give you a hint. I don't know where F is. Okay, good. All right. so, so yes, that's the live one. Remember, IPV is not live. Remember, OPV is live. Okay, so, all right. So why is live important? They love to hit questions about live vaccines because there's certain patients who shouldn't get live vaccines. Okay, so you need to know the big ones that we use commonly in practice. So MMR, varicella, rotavirus, and then the intranasal flu vaccine, okay, which is approved for children older than 2. And we'll talk about that in a minute. There's also a couple of other live vaccines, but they're only really going to be given to kids who travel. So the oral typhoid vaccine and then yellow fever, which I doubt they're going to ask you about those on the initial certification exam. But if they did, just realize that it's the same precautions with these with someone who's immunocompromised, what you need to be worried about. And mainly what you're talking about here is someone who just recently had a bone marrow transplant or someone who's got some type of you know, immunologic disorder like common variable or something like that. We're going to be very scared about giving them a vaccine that's live. Okay, remember that all the vaccines that we give before a year of age are either killed or recombinant. None are live except for that rotavirus one. Okay, so the rotavirus is the only live vaccine that a kid's going to receive in the first year of life. Okay, so the organization's charts, as you know, are 0 to 6, 7 to 18. And it's real important is you remember where that cutoff changes, because the important one that they'll ask you about is that tetanus one, okay, the ones that involve tetanus because of the diphtheria portion of that, the big D, because that's where the switchover occurs is at 6. So at 6 and younger, they're going to get the big D, and then after 6, they're going to get the little d, okay? So you need to look for a little d in the test question for the kid older. And you got to remember that cutoff. They love to do cutoff things. And then we're going to have to figure out how to catch up some kids, and we'll talk about that. Okay, so this is blurry in your handout right there. If you go to the very end of this handout, we've got them in the PDF format directly from the CDC. So when you go ahead and study, you've got the real form there. So I'm not going to spend time going through the schedule here because we're going to talk about these individually, but they're listed for you in the back. And this is the most important part of this whole talk, is you have to know this, okay? These footnotes, don't ignore. This is where they get the questions from. Okay, this is where you are a pediatrician. Okay, you understand these footnotes, and if you read them, you actually understand them. Okay, you do this all the time. The problem is that there's some things in here that we'll go through that you need to really, really remember, because they're going to be very specific for some of these vaccines about why we do things for certain ages or certain size kids, or for if they're immunocompromised or don't have a spleen. So some things will change a little bit, but you've got to know the footnotes. And again, at the very end of your packet, you've got those in where you can see them really well. Okay, so this is the 7 to 18 group, and then here's the footnotes for that one, and then here's the catch-up immunizations for this, and here's the footnotes for that one. Okay, all right, so let's talk about rotavirus here. All right, so rotavirus. So prior to the introduction of the vaccine, most kids were infected by age 5. It's the most common cause of gastroenteritis in infants and young children. And the biggest problem is in the developing world. Okay. So which of the following should not be given rotavirus vaccine? Okay, so we said already it was live. So maybe they're going to ask me about that. And you look through and it goes, maybe that's not about that. So should you not give it to an infant at 14 weeks and 5 days of age receiving their first dose? Should you not give it to an infant who has received one prior vaccine, is now 8 months and 1 day old? Should you not give it to an infant who received amoxicillin 2 days ago? Should you not give it to an infant with Down syndrome? Should you not give it to an infant with 100.1 degree fever? So what do y'all think? Who should not get the vaccine? Good. Okay, so B as in boy is the right answer here, okay? B is the right answer here, and this is how this is the trick. They want you to know these little cutoffs. So a kid older than 8 months and 0 days does not get rotavirus vaccine. The whole point of giving it is to protect them when they're under 8 months of age. After they're 8 months, if they get rotavirus, it's okay. Their chance of having a big problem from it is very, very small. Okay? So that's the reasoning here. And then the A people, actually you can give it through 14 weeks all the way through the 14-week period. Okay? Now, if they showed up at 15 weeks, no. Okay, so they're going to be very, very specific about this. Okay, they want you to know these particular cutoffs. All right, so there's two different ones available here in the States. They're both oral. One is a 2-4-6 month schedule. One's a 2-4 month schedule. I don't think they're going to ask you about picking, which brand, because the boards are very good about not playing favorites with drug companies and recommending one vaccine over the other unless there's a specific reason to. And there's really no particular reason here. So the main thing is you need to know 2 and 4, 6 months, which is kind of the usual schedule for most of these vaccines that we're talking about initially. And remember, the minimal age for the first dose is 6 weeks, and then the minimal interval is 4 weeks. And intervals are important. They want you to know intervals, okay? So make sure you're familiar with these. And this is the most important part of this slide, is this last bullet. So you are not going to give vaccine to, so if the kid shows up for some reason, has never had rotavirus vaccine, they show up in your office at 15 weeks, 0 days, they do not get rotavirus vaccine. Or if they've gotten one dose sometime in the past and now they show up and they're older than 8 months, 0 days, they don't get vaccine. Okay? All right, flu. Just briefly on flu, I got a little just email blurb. There's a new swine flu that's going around right now in August. And actually, I think one of my former residents is here and told me she diagnosed a couple kids last week in her clinic, which is just east of here. And the swine flu thing is here in Texas. So some of you have fever. Or a couple of you have already come up to me and told you have fever and cough. Please stay away from me. But you might have flu, so you might want to think about going to get tested while you're here and get some Tamiflu if you really are having 100, 200, 103 fever and a cough, because there's evidently flu here in Texas right now, and it's a new variant of a different swine flu. So guess what? Your next couple of months are going to be bad if this thing. You remember 2 years ago? Okay. So here we are again. We don't have a vaccine for this one, so we'll have it about December, and the thing will be gone, right? That's what happened last time. Okay. So just warn you that it looks like it's going around. The other thing we have here, you saw they have in Texas here right now, is West Nile virus, and we'll talk about that this afternoon. So welcome to Dallas. Okay. 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 So who's eligible for flu? Let's talk about flu vaccine. Remember, it used to be this whole risk assessment, blah, blah, blah. Now just give it to everybody, okay, which just helps you on the test. Because everyone should get it, okay, unless they give you something why they shouldn't get it. But everyone beginning at 6 months of age should get flu vaccine, especially very important for those who are at increased risk of complications. So they're likely to give you one of these kids here, and you need to know for sure they should get flu vaccine. So they're really, really pushing for the 6 to 23-month-old kid to get flu vaccine because they have a higher rate of complication. Aspirin therapy is still there because of the concern about increased risk of Reye syndrome. Any pulmonary cardiovascular disease, and this includes asthma, so you want to make sure your asthmatics are immunized. And then all these other things here, the spinal cord injuries, cognitive dysfunction, any kid who's in a chronic care facility should be vaccinated. Obviously, everyone should be, but those are the ones they may hit on the test to say, should you really get this going? The answer is yes. So remember, with flu vaccine, we have to give it every year. There's two types. There's the inactivated one, which is the shot. Okay, minimal age for that is 6 months for the shot. And then there's a live intranasal one that's available for anyone 2 to 49. Okay. Now the key thing here with this one is it's live, and they may give you a pregnant adolescent and try to get you to give her, flu vaccine. Now I'll probably say this a couple times today, so let me just say this now. Are there pregnant women here? Could you raise your hands? Okay. I apologize to you profusely, okay, from what I'm about to say. But on the exam, if there's a pregnant woman, she is evil, okay? If there's a pregnant adolescent on the exam, or if there's a woman who has kids, that you're seeing the kids, and she's pregnant, she's evil. Because what they're going to try to do is give you or try to cause you to cause harm to her or to her developing baby. Okay? And so they're going to try to make you give her something like a live vaccine, which we don't do. We don't give live vaccines to pregnant women. Or they're going to try to make you give her doxycycline, which we don't do. Okay? So for purpose of the test, just remember she's pregnant or their mother's pregnant of the kid that you're seeing in the test question. Be very, very suspicious, okay? She is there to cause you harm, okay? And there's no reason to make her pregnant unless they're trying to get you to figure out why, something different here. So this woman, so pregnant women should not get the vaccine, okay? Should not get the live virus vaccine, okay? Pregnant women should definitely, and this is what they'll ask you because you'll hear, oh, they shouldn't get flu vaccine. No, they should only not get the live flu, the intranasal. Pregnant women definitely need to get the regular shot vaccine, okay? It's a definite. That's who we saw the biggest complication rates in the last epidemic 2 years ago. We had a whole bunch of pregnant women who were in ICUs. So you've got to make sure the pregnant women are immunized. Okay. They also say don't use the intranasal one in a kid 2 to 4 if they've had wheezing in the last 12 months. Okay. So I would remember that one. They might give you a 2 or 3-year-old who had an RSV thing or something in the last 12 months. And because you're worried about if they really have asthma or some kind of underlying respiratory thing that they could have a reaction to it. So they just say don't do it. So 6 months to 2 years, you're going to give the inactivated vaccine. And then there's this other Fluzone that's approved, is the only approved option for this group. And this will change probably this, I don't know what, I haven't read yet to see which one is available. They won't ask you about that. You just know 6 months to 2 years, the only vaccine you can use is the inactivated one, the shot. Okay. So the first flu vaccine ever, and they're under 9 years of age, then you know you need to give 2 doses separated by at least 4 weeks to the first-time kid. Okay, I would know that. Okay, so that 6-month-old that you give their first shot to, they need to come back in 4 weeks and get another flu shot. After that, they just need 1 dose for the following year. Okay, who should not be vaccinated? Now, you all know this is a huge, big deal now because now they say eggs allergy is fine. Okay, it's fine. Now, it's debated because some people, are not comfortable with it. But the deal is you can give the shot and you need to observe them for a period of time. There's actually specific guidelines. You need to have things set up in your office to be able to do this. A lot of people will just say, I'll just send you to the allergist and let them give you the flu shot, and you can sit there and anaphylax for them. But the reality is that it's really rare. Okay, that's why. Remember with for those of you that are too young, we used to not give MMR to people who had egg allergy because we thought it was going to be a problem, and now we give MMR to anybody with an egg allergy without any problem. So anyway, so I think for the test they could ask you about this, and you would just say you can give it, but they need to be under supervision for a period of time after you give them the vaccine. Okay, and your office needs to be set up in case they do have a reaction that you can take care of. If they've had a severe reaction to a previous vaccine, so severe to me would be anaphylaxis or something like that. If they had Guillain-Barré syndrome within 6 weeks of getting a flu vaccine, so if they give you that history, they should not be revaccinated with flu. Obviously, a kid less than 6 months of age should not get it. And then if they have a very severe current illness, then they're less likely to respond. So if you're putting them in the hospital with a severe pneumonia or something like that, then you want to wait till they're better before you give them the vaccine. All right, pertussis. So recent changes with this, and they're going to hit on this for sure, is the Tdap vaccine. Remember, this replaces the adolescent booster, so everyone should be getting a Tdap. The other thing they're going to ask you about is, have you had your Tdap? Because you, as a pediatrician, are seeing young babies, and anyone who is around young babies and who takes care of them should be getting a Tdap. So they're going to ask you on the exam, possibly, should you get a Tdap? And the answer is yes. Okay, you want to make sure. They may ask you about grandma who's taking care of the baby. Should she get Tdap? Yes. So really, anyone who is around children, particularly infants, needs to get a Tdap. Okay, the new Tdap vaccine, and it's approved now for every age adult. There's no cutoff anymore. So every age adult can get the Tdap now. All right, so why do we add pertussis? Well, as many of you know, we have a huge outbreak going around the United States and various parts of the country, including Dallas. So I don't know about that. I just made that up. But but there's 3 parts to it. And then the way the guideline is now, which I don't think they'll ask us about because in pediatrics, generally this gets past us, But once you have one Tdap, they say that's all you need. You can go back to the TD booster. Well, the problem is, as you all know, no one keeps this in their office anymore. I mean, because everyone needs Tdap, so you're not going to pay money to keep this old vaccine around. And so we think gradually what's going to happen is they'll just change and say it's okay to give, they need more safety data to say, is it all right to keep giving this Tdap thing over time? But for now, they say just do a subsequent booster with the big T, little d. So I don't think they'll ask you about that. In the real world, no one has it anymore because everyone's got Tdap. Now, this is important because this is one of the footnotes that was added recently. And remember, it was only approved for, one was approved for kids 10 and older, one was approved for 11 and older. And so you're like, well, what do I do about the 7 and 8 and 9-year-old? Well, what they say here is that children 7 to 10, so if you're bringing them in for catch-up and they've not had pertussis, they get the Tdap. Okay, it's okay to give them Tdap. So I would know that. They may give you a 7-year-old who's behind on pertussis vaccine. It's okay. They say it's okay to give Tdap. Now, I don't believe it's FDA approved, but for the boards, it's okay because the AAP says do it, okay? And there's pretty good data that it shouldn't be a problem, as far as in anything. And then what they say is keep using the TD. Well, again, you're not going to do that because you don't have any. But for the boards, just know if 7 or 8 or 9-year-old comes in, give them the Tdap, okay? Give them Tdap. Okay, H flu pretty much, was gone, thank goodness. And this vaccine came out in the late 70s, early 80s is when we started using this a lot. So essentially, we've just gotten rid of type B, but what we're left with is the non-typable forms of Haemophilus. So we still see otitis media, as you all well know, and upper respiratory infections from this. The schedule for Hib, 246, 12 to 15. Minimum age is 6 weeks, and then depending on the brand of Hib vaccine that you use, you may not need the 6-month dose. Okay. Again, they're not going to ask you specifically because they're not going to care which one you use in your practice. You just need to know, they need to get the vaccine. Okay. The other thing they may ask you about, it's not if they come. Let's say they come from another country, they never got Hib. They show up at 6 years of age, know that they don't need to get Hib. Okay, there's no reason to vaccinate someone older than the age of 5, unless they've got some reason to be, like if they have sickle cell disease, or leukemia, HIV, or they don't have a spleen. Okay, those are the big ones. All right, Hep B. There's a lot of controversy initially for this for a few years ago, with more than that now, but because of the mercury that was in the hepatitis B vaccine and the concern about giving it to a newborn in the nursery, giving mercury vaccines, and that's been taken care of now, so it's not an issue. But the first dose is the monovalent Hep B. You want to try the recommendations is to give it before discharge from the nursery, and then so they get 3 doses at birth, 1 to 2 months, and then 6 to 18 months. If they don't get it at birth for some reason, then give it at their initial visit, then a month later, and then 6 months later. And then if you're in this group here, there's a combination with hepatitis B with some of the other things like Hib, and so you may, if all you have is a combination vaccine in your clinic, then they say it's okay to give them a 4th dose. All right, so I don't think they'll ask you that, but that's probably more just for practice purposes. Now, the next couple of bullets here are really, really important, are always hit on the test. So the first one is the mom who's got hepatitis B. She's got active hepatitis B. She's surface antigen positive. What you want to do is at delivery or soon after delivery, give Hep B vaccine and the immune globulin within 12 hours of birth. And then what they demand that you do is you have to follow the baby, and you want to first document that the baby's hepatitis B surface antigen negative now at the time that you're doing this. And then you want to make sure that they develop antibody after they get the vaccine series. And they actually want you to test these babies. Okay, so down the road, after they finish their 3rd shot, you want to go ahead and make sure they actually got, protected. All right. If the mother's status is unknown, which is rare to occur, but on the exam it always occurs, then what you want to do is you want to give vaccine. Okay, well, here's how they separate this out. Depends if the kid's bigger than 2 kilos or below 2 kilos. Okay, so if they're bigger than 2 kilos, then you're fine just to give them the vaccine. If they're younger than 2 kilos, then the recommendation is they get the vaccine and they get the immune globulin, okay, within 12 hours of birth. And then what you want to do is determine the mom's status as soon as possible. And in that kid who was greater than 2 kilos, if the mom's surface antigen comes back positive, then you want to give that child HBIG within that week. Okay, so the smaller, potentially preemie kid here is the one that you worry about that they won't respond to the vaccine, so you're going to give them HBIG to protect them right away. The kid who's bigger is likely to develop, be fine just getting the vaccine. If for some reason mom is surface antigen positive, at least and then if she does turn out to be that way, you go ahead and give the HBIG within a week, and you really protect the kid completely. All right. The other thing they love to ask you about is they've got, this adolescent or whatever that hasn't, for some reason, they got 2 shots and they haven't had their third, or they've had one years and years and years ago, and it's been 15 years, and they've never had their second shot, and the answer is you give it, okay? And you don't start over from scratch. Okay, this is new. I think I would know this. Is that for all ages, you can administer the usual 3 doses. And there is for 11 to 15-year-olds now, you can do the Recombivac's with just 2 doses, 4 months apart. Okay, so I would know this. They might ask, this is one time they may ask you about a particular vaccine. And just say, is this okay? And the answer is yes. Okay, Hep A. Every kid over 1 should be vaccinated. It's 2 doses, at least 6 months apart. They're likely to give you some kid who's an immigrant who comes in and hasn't been vaccinated, and they want you to ask, should you vaccinate them? And you say yes, go ahead and vaccinate them. The other thing is that you need to know is that if there's an exposure in a household or family, you can give hepatitis A vaccine as your post-exposure prophylaxis instead of immune globulin. Okay, that's acceptable now. So you just vaccinate people instead of giving immune globulin. Okay, meningococcal vaccine. A couple things will come up. There's 2 vaccines now, as you know. There's the old polysaccharide vaccine, which we still use in some patients, and then the meningococcal conjugate vaccine is the one that everybody gets. So for patients not in the high-risk group, which means patients who don't have any underlying medical conditions, which is your normal everyday kid, the recommendations are now, and this is changed again, so it's a little confusing, but they want you to vaccinate at 11 to 12, at their 11, 12-year-old visit, and then booster them at 16. Okay, that's the recommendation. That's what the best practice management should be. Okay. If they missed for whatever reason at their 11, 12-year-old visit, then they say give 1 dose at age 13 to 15, and then the second dose at 16 to 18. Now, if the first dose, for some reason they don't show up until age 16 or older, then you're fine just giving 1 dose. Okay, and I know that's confusing. Go back and read it and just be familiar with it because they're likely to give you this little scenario here. So depending on their age, they're going to tell you when to give it and how many doses. On the exam, though, for sure, look out for the kid who's going to college, is going to be living in a dorm as a freshman going to college, and they've never been vaccinated. You know for sure you want to give them that 1 dose. Okay, they're going to need it. Now, for high-risk patients, if we talk about like if they've got a complement deficiency or they've got a splenectomy for whatever reason or asplenia or sickle cell disease, then what you want to do is you can give 2 doses at least 8 weeks apart between the ages of 2 and 10, and then you're going to do 1 dose every 5 years thereafter. Okay. So that they have, so obviously if your spleen is gone, you're not going to get it back. So once you've had your 2 doses, then you need to remember somewhere in the chart or on the test, you need to remember every 5 years while they're in the pediatrician's care that they should keep getting this vaccine. In adults, it's murky. Okay, we'll get 1 more, and then no one knows really what to do. But for now, in pediatrics, it's pretty easy. They just say give it every 5 years. All right, chickenpox. Okay, the following are all true about the varicella vaccine except. Okay, so which of these is not true? So it is a live vaccine. 1 dose is required. It contains small amounts of neomycin and gelatin. The vaccine can be given as early as 12 months, or 5% of recipients get a mild case of the chickenpox. Which of these is not true? Okay, good. So sometimes they ask you these stupid things here, like who cares about neomycin? Or, well, the reason is because some people are allergic to it. Okay, so you just need to be aware of this. And be very careful in the question stem. If they talk about, look for allergies, if they're talking about vaccine, and just, if they say neomycin, which I don't know why anybody would get neomycin, but, I guess it's in the over-the-counter stuff, but they say a kid is anaphylaxis to neomycin. Be careful with this vaccine. This would be one you'd not want to give to them. But the answer is y'all are correct. B, because you have to have 2 doses, right? Okay. So let's talk about this. So the timing of the vaccine, what they recommend is you get the first dose sometime between 12 and 15 months, and the second dose at 4 to 6 years. The 2 doses should be administered to all, so everyone now gets 2 doses. Okay. They recommend a minimal interval for those, so this is new, so I know this, is the recommended minimal interval now, so for a kid between 7 and 12, so they didn't get it during their, for some reason they show up now at 7 to 12 years and you need to catch them up. The minimal interval between the 2 shots should be 3 months. Okay. The old recommendation was 4 weeks, but now they realize they get a better immune response if you give it 3 months, at least 3 months separated. Now, if for some reason they got the vaccine in the past, or say went saw someone else and they got 1 shot, when they turned 7, and then 4 weeks later they got the second shot, they say it's still acceptable. You don't need to revaccinate them again. But the best practice is to do it 3 months apart. And then once they're 13 and older, then you can go to every 4 weeks. So something in this age group, they just don't respond as well. So they want you to go a little bit longer on the interval. I would know that. That sounds like a classic thing the boards would pick on. Okay, for varicella in adolescents, so they tell you, okay, the kid's never been vaccinated and they've never had chickenpox, and they want to know what do you do, and they will ask you, should you check a titer, and the answer is no. Just go ahead and just give them vaccine. Give them 2 doses and just go with it. Titers are not recommended by the AAP. Okay, here's some other groups you need to be careful of. They'll probably give you is some kid who's on inhaled steroids. Okay, inhaled steroids, remember, are not a problem. They can get live vaccines with inhaled steroids, particularly chickenpox. Children with asthma, or if they're on oral steroids and it's less than 2 milligrams per kilo per day. So that's the magic number you need to remember there. If they're on less than 2 milligrams per kilo per day, then they can go ahead and get the varicella shot. Okay. And the other one they love to give you, again, is the pregnant woman there's woman's pregnant and she's got kids who need vaccine, chickenpox vaccine, and they want to know, should the kids get the chickenpox vaccine? Yes. Okay. Should the pregnant woman get chickenpox vaccine? No. Okay. So that you need to know that. So don't get confused there. Pregnant women do not get the vaccine themselves, but their children can definitely get it. Do not vaccinate people who are on higher dose steroids. By that they mean 2 or more milligrams per kilo per day. So 2 or more milligrams per kilo per day. If they're on that, then you want to hold off until they get to they're kind of tapered off that steroid dose if possible. And then pregnant women, for sure, you don't want to give it to. They may ask you about a pregnant woman gets a live vaccine. What do you need to worry about? Probably nothing. Okay. I mean, there's not been any problems with this, but it's just because it's a live vaccine that we don't want to chance that there's a potential problem. They may ask you, she gets an MMR, what should you do? And the answer is there's nothing really for her to be concerned about, but it's just something we don't recommend because of the potential that there might be a problem. Okay, so what about varicella and MMR? Remember, we can give them on the same day, and here's where they love to ask questions about this stuff. Okay, so just kind of star this one, know this one as best you can remember. So varicella and MMR can be given on the same day. Okay, but if you don't, then you want to wait at least a month. Okay, so the varicella and MMR aren't given that same day. You want to wait at least a month before you give the other one. Now, this is the time to wait for varicella or MMR vaccine after these. So if they've gotten tetanus immune globulin or immune globulin for Hep A, which remember is a very small dose of immune globulin, or they got H-big, so they got any of these kind of immune globulins for these specific diseases, you need to wait 3 months. They may ask you about, some kid got his RSV, antibody, and it doesn't matter. You don't worry about that. Or if they've gotten washed red cells for whatever reason, if they say that, none. But if they had packed red cells, you need to wait 5 months. So if they weren't washed, if they got whole blood for whatever reason, 6 months. If they got plasma or platelets, it's 7 months. And then if they got IVIG therapy for ITP, you need to wait 8 months. And if they got IVIG for Kawasaki, so the huge whopping dose, you got to wait 11 months. Okay. So the reason is because with these immune globulins down here, as well as with plasma or platelets, there's antibodies in there, and so the patient may not respond to the MMR until these antibodies are gone. So they're not their own antibodies there, so they don't respond to the vaccine very well. So I would know that slide well. All right, pneumococcus. There's a conjugate and polysaccharide. Remember, for this group, high-risk groups, and don't forget cochlear implant. For some reason, they love to hit on that one. Okay, that's a big one. Cochlear implant, kids should definitely get both. People with underlying cardiac or pulmonary disease, not asthma, but if they've got bad cystic fibrosis or something like that. Immunocompromised patients, anyone who doesn't have a spleen, and if they're on long-term steroids. So the conjugate vaccine, now we're the PCV13. This will eventually won't be a problem for you, but on the boards this year it still probably is maybe a problem because, when we made that transition from 7 to 13, there was what do you do about this? And so they made this very complicated, and so they might have a question about this for some reason. So remember, we give it at 2, 4, 6, and then 12 to 15, our normal little shot times. And then let's say they didn't get vaccinated or they got incompletely vaccinated and they show up between 24 through 59 months. Then they get 1 dose. So if they never got anything at all, but now they show up at 25 months, you give them 1 shot of the pneumococcal vaccine. If you started with the 7 and now you switched over to 13, so let's say they got 7 at 2 and 4 months, and now they're showing up at 6, and you've got the 13, we'll just switch over to 13. You don't have to have like 4 13 shots, okay? If they show up, if they got a complete series though of 7 for whatever reason, and now they're showing up between 14 to 59, they say go ahead and give 1 dose of the 13. So you just act like they never got anything. Okay, they never got anything. So you treat them the same as that. And then 1 dose of the 13s recommended for all kids 60 to 71 months with underlying conditions who completed their PCV7 slide. PCV7 appropriately. And then you want to use 13 should be at least 8 weeks after the previous dose of the 7. So that's the other thing they might ask you about. This is going to go away, obviously, in the next year or so on the exam because you haven't used 7 in a while, but it still may be there at this point because some of these kids may be out here and for some reason, didn't get 13. All right, the polysaccharide vaccine, the old vaccine, it's still recommended in pediatrics that you administer this even though they've already gotten the 13. And what you need to know is for these kids, the cochlear implant or their asplenic, that you still give the polysaccharide, but you want to wait at least 8 weeks after their last dose of the 13. Now remember, the polysaccharide you can only give to kids who are 2 and older. So polysaccharide vaccines you only give to kids who are 2 and older. So they would have completed their 13, and now they're coming to you at 2 years of age or 2.5, and no, it's okay then. You just go ahead and give them the one polysaccharide vaccine. The reason is there's more antigens in this one than in the other, and then in 13. Okay, briefly on polio. Times for you here. They want what they say specifically is they want the 4th dose to be after their 4th birthday. Okay, so and remember we use the inactivated one. Now the OPV, there may still have a question about it on the test for whatever reason. Okay, so how many of you have never used oral polio vaccine? Okay, that's what I thought. Okay, so but hey, you might still get asked about it. So just remember you don't want to use it in HIV family. So if the mom's got HIV, the classic question supposedly was, if there's a mom who has HIV in the family and the baby's not infected, can the baby get oral polio? And the answer is no. Okay, the mom's changing the diapers. There's some concern that potentially that she might have a problem from the oral polio vaccine. So if there's an immunocompromised household, we don't use oral polio. I don't think they'll ask that anymore, hopefully, because no one's used it in forever. Just more on this. Again, this is the one vaccine like this where if you live in a household with an immunocompromised patient, you're not going to use it. All right, so by 18 months, you've got all these vac shots that the kid's gotten, and the underlying ones you're done with, okay? Pretty much you're not going to have to worry about in the regular, normal kid after that. And then they come back again at 4 to 6, and you get, the kindergarten special again. And then all these are usually done by age 7 at this point in most kids. And then there's very few contraindications, okay? And on the test, if you don't know, just vaccinate. It's probably the right answer, okay? Because they're going to try to give you some weird, crazy thing about or bait you into thinking that there's a contraindication, and it's probably not. I mean, there's very, very few, and we'll talk about those in a second. The key thing here is they're going to say, oh my gosh, he's got 101 fever, and he's got a runny nose, and he's got otitis media, and he's fussy, and he's crying, and it's like, okay, give him the shot. It's the test. It's not the real world, right? You just move on and give him the shot. Okay, and the parent agrees. Oh, this is perfectly fine. Yes, give him the shot. Okay. And again, don't forget, they come in for the broken arm. Oh, Johnny, you didn't have your varicella vaccine. Let's give it to you today. Okay. Yeah, sure. Like the kid's going to be ballistic then. Okay. Which of the following is a valid contraindication of vaccine? So fever of 101.5, otitis media, irritability following a previous vaccine, a seizure 1 day after a previous DTaP, or allergy to penicillin. Okay, good. So this is the one. This is one they might give you, okay? But they really don't like to give you a contraindication because they really want you to immunize everybody, right? You see people on the street, just immunize them, I mean, that's what they want you to do. All right. And some people get confused with penicillin and neomycin. Penicillin, there's no penicillin in any vaccine. Okay, they're never going to put penicillin in a vaccine because so many people are allergic to penicillin. So don't worry about that. All right. And always, I don't care if they have fever, I don't care if they have otitis media, just give them the shot, okay? Just give it. So the true contraindications, a seizure 1 day after a previous DTaP, and then none of the others were true. And do not vaccinate. So if someone has anaphylaxis to a vaccine, don't do it again, okay? So don't go, let's see if the MMR really did this or not. No, don't do that. Here's the ones here that I would just kind of remember in the back of my head. If they, the egg antigen, pretty much is gone. So if they ask about it, they may ask you about how to handle flu vaccine in these patients, and the answer is probably immunize them just under, you watch them for a while. Yellow fever, they won't ask you all about. These antibiotics are in IPV, streptomycin, which I don't know why a kid would get streptomycin. He had tularemia and he anaphylaxed to his streptomycin. Then don't give him the IPV. Okay, so neomycin is in MMR and varicella, and gelatin's in MMR varicella. But if they just had like soreness or redness or a little rash, you're not going to worry about it. But true anaphylaxis, you would always not redo. And then they say if there was an anaphylactic reaction, then you can skin test them. But I think most people, depending on what the vaccine is, you really want to protect them. You may skin test, but if it's not, anyway, I guess there's all vaccines are important. But anyway, for the boards, they say skin test, so you can go ahead and maybe give them the vaccine. Okay, you want to expect side effects, so they may ask you about this on the test. Side effects are common. They commonly look like a viral illness. Everyone gets a flu shot, and they say, "Oh, you made me get the flu." Okay, I mean that's the reason why adults don't like to get the flu shot, right? Because they say, "Oh, it makes me sick." Well, it's just because you're having an immune reaction and you get a little, yucky feeling, but you're not having flu. I mean, there's no flu, there's no flu in that shot. So, but you'll get symptoms maybe that you have had a viral illness just from your reaction to it. You expect local tenderness, you expect low-grade fever, and you expect minor irritability. Okay. If they talk about a kid who's got really bad irritability or high fever after their shot, then you want to have them evaluated. So the classic scenario will be you get a phone call on the test. You get the phone call from the mom, and she's worried because her child is lethargic lethargic or extremely irritable and they've just got their DTaP that morning. You want to have them come in and be evaluated. Okay, so you arrange for that to happen. And use of acetaminophen. This is very controversial. I don't think they'll ask you about this. Okay, these are the ones they're going to try to give you and make you not give give vaccines. So, they say, oh, I had swelling in the arm after my shot. Well, that's okay. Just give them the shot on the test. They had mild acute illness. They had low-grade fever. At the time they show up on the test, just give them the vaccine. So again, otitis media is a classic one they like to give you. The ear is bulging. It's red. It's going to explode. And they go, do you want to give vaccine? You go, yeah, give vaccine. Okay, I don't care. It's a test question, And then if they're on antibiotics, say, oh, well, he's on amoxicillin. It doesn't matter, And they say, well, there's sick people in the house. Well, it doesn't matter. Give them the vaccine. Okay. All right, allergy, history of penicillin allergy, so that sometimes they bring that as a concern, or some nonspecific allergies. That's not a reason not to be vaccinated. They say, oh, we have a history of seizures in the family, to vaccines. That's not a reason to vaccinate, not to vaccinate. There's somebody in the family who died from DTaP, 20 generations ago. Just give it on the test. And then they talk now, so TB. So there's something with TB and immunizations. And I think I talk about it here. Yes, I do. So the big deal with, if they have active TB or they're PPD positive. So you'll see PPD positive and you'll get confused. Like, well, that means don't give some vaccine or something. Well, no. Give vaccines. You give the vaccine. Now, we'll talk about how that's going to change with MMR here. So what about the PPD and MMR? And this is where people get confused. So we know if you give measles vaccine and you place a PPD a couple weeks later, it may suppress their tuberculin reactivity. Okay. The key is it's okay on that day to place a PPD and give them MMR at the same time. Okay, it's okay. The recommendation is, though, if you give the MMR today, and for some reason there's an exposure history 2 weeks from now, then you need to wait for 6 weeks after their MMR, because the MMR, for some reason, the way that it works is going to cause the tuberculin reactivity to be diminished. So cell-mediated immunity seems to be diminished during that time period. So this is so they can have active TB given the MMR. Okay? If they have active TB, give them the MMR. What this is talking about is if you're trying to test someone for TB and they've had an MMR, you need to wait 6 weeks after the MMR before you do it, unless you do it on the same day, and then it's okay. All right, contraindications to DTaP. This is the one that people worry about the most because we have the most history with this. So you don't want to revaccinate if they've had a history of encephalopathy within 7 days of the vaccine. And then that's a definite do not. These are seriously consider. Okay. Now, the problem with seriously consider for me is on the board test, that's my decision and the parent's decision, and we meet together and discuss that. So there's not going to be a right answer for the test. Okay? So they may ask you, should you consider, is this something you need to talk over with the parents with these? Yes. But I wouldn't spend a lot of time memorizing these because it could be the right answer, it could be the wrong answer, depending on what the parents and you decide is best for the patient. It's not an absolute. Okay? The first one's absolute. These are seriously consider whether the patient should be revaccinated or not. Okay? So those are harder to test because there's not a right answer. The other thing you need to know is there's no evidence that seizures after so if the kid does have a seizure after a DTaP, are they going to have neurologic damage or epilepsy? The answer is no. Remember the MMR, we can give it. Egg allergy is fine, but neomycin, gelatins, the big ones they might ask you about. You don't give it to a pregnant woman, and you don't give it to an immunodeficient patient except the healthy HIV-infected patient. So if the kid's got HIV infection and they've got a good CD4 count, you're going to be fine. Go ahead and give them the MMR. The other thing they think they will ask you about, because we had all that controversy about autism, MMR does not cause autism. Okay. I know it's like that. Okay. I love that. All right, at the back of this section are 20 questions for you to do for homework over the period of time whenever you want to. So go through those and make sure you're very, very comfortable with them, and they're going to hit a lot of the footnotes. All right.